Okay, hello and Merry Christmas as it's December. The panel are looking at me slightly stunned for the Merry Christmas, but I think, you know, we should get into the Christmas spirit as we're just in December. So Merry Christmas and welcome to today's meeting of the Health and Social Care Select Committee at London Borough of Hillingdon. This meeting is being broadcast on the Council's YouTube channel Hillingdon London. The purpose of this committee is to monitor services provided by health partners in adult social care and review their performance. We also undertake an in-depth review and witness sessions on specific topics and submit our findings to the decision-making cabinet. My name is Councillor Nick Denys and I'm chair of this committee. Before we start, I have some important housekeeping for everyone present. Please ensure your mobile phones are on silent. We're not expecting a fire drill, so if the alarm goes off, please follow Nikki out of the building. Please keep your microphone muted when you aren't speaking, and when you aren't speaking, then unmute to speak. As chair, I'll call on those to speak in the meeting. It's worth noting that some councillors in the committee may be using devices to access agenda and papers. Right, so we're going to move on to the agenda. Nikki, do we have any apologies for absence?
Chair, we've had apologies from Councillor Becky Hagger and Councillor Peter Smallwood, who very kindly agreed to substitute for her. Thank
you, Councillor Smallwood. You're very welcome. And we have a new councillor on the committee tonight, Councillor Bassett, who is a new member. So welcome to our committee, Councillor Bassett. And also a big thank you to Councillor Nelson, who's no longer on our committee and has been on the committee for as long as I've been on the committee, which is a number of years. So if you could put our thanks to her for all the work she's done in the health and social care space, that would be very appreciated. Thank you. Right, is there any declarations of interest? Councillor Smallwood?
Chair, if I could apologise to you and to the committee for my appearance. I usually pride myself in wearing a suit. I'm sure the festive spirit will become on me, but Councillor Hagger asked me, through no fault of her own, with late notice, that she was unable to attend this evening. I was already here at the Civic and I thought I'd read the papers rather than go home and look glamorous for you. So I apologise for my appearance.
Well, it is the season of jumpers. So if you are going to wear a jumper at a select committee meeting, today is probably the good one. That's completely fine, Councillor Smallwood, and it's a very nice jumper. So that's an added bonus. Right, that's it on declarations of interest? Yep, fantastic. Minutes of the meeting on the 11th of November 2025. Does anybody have any comments on those? No? We agreed? Fantastic, thank you. Item 4 is about exclusion of press and public. Everything's in public, isn't that right, Nikki? Yes, fantastic. Okay, so we can start with our first major item, which is the health updates. And we're going to start with Hillingdon Hospital. So Jason Sees, Deputy Chief Executive of Hillingdon Hospital, is here. So Jason, could you give us some of the highlights that was in the paper that was sent to us?
Can you hear me all right? Yep. So we've got two papers on the agenda today. One is a redevelopment update and one is an update on the trust running. So if we are content, I'll do the redevelopment and then pause for questions if that's all right. So as detailed in the paper, gosh, time flies. So we're here in June this year, and that was sort of very much in the context of the good news that following the general election, we had a new Labour government. They undertook a review of the new hospitals programme, and they announced in Parliament in January that the new Hillingdon Hospital would be in Wave 1, which is the sort of new terminology for how the hospital builds will go forward. And sort of in that context, we were the only scheme in London to secure a Wave 1 sort of position. So again, as ever, a big thank you to everybody around the table, because a key part of that was about how Hillingdon absolutely provided a united front on going forward and what we were doing together. So we had that in January. In April, we had further sort of correspondence from the Minister for Health confirming what the requirements were going forward. And so since then, we have signed a partnership agreement with the new hospitals programme. So the NHP, as they're sort of known as, is the Department of Health and NHS England. So we've updated our relationship with them. And as part of that, it is now mandated that we design our hospital in line with something that's called Hospital 2.0. And that at a very simple level, is a standardised, what you could almost see as a Lego set for how you put hospitals together in a standard design. So previously we've been here with a previous design that we've got full planning approval for currently. In the paper where we sort of reference we're going through a design process, what we're doing is refreshing our previous design and ensuring it's Hospital 2.0 compliant. So there's something called REBA stages. So when we sort of say stage 1, that's REBA stage 1, and then stage 2 is REBA stage 2, where you sort of make the design a lot more clearer and sort of really get into the detail. So that's all working its way through. Again, as ever, huge amount of clinical engagement. And then when we get that REBA 2 design sort of more worked up, that's when really the stakeholder piece and making sure everybody's involved will ratchet it up again, because we want to make sure that, again, that design is owned and sort of developed with all our partners. But in the context of it will now be a Hospital 2.0 design, so a lot of it is just mandated about how the hospital goes together. In terms of the paper, we've just given you some headlines on the times going forward. So when we say contractor selection and onboarding 2026, in a sad way, that's quite an exciting headline. That's sort of getting the builder on board. So what's going through at the moment is the new hospitals programme are selecting a number of, obviously, the sort of bigger builders, both in Britain and Europe. What will happen in the new year is we'll go through a selection process with the new hospitals programme, and then we will secure a builder for the new hospital, which will allow us to take forward that design with them, finish the outline business case, 2026, full business case 2028, construction starting in 2028, which was in line with the Secretary of State's announcement, and then the new hospital open to patients towards the end of 2032. So huge amount going on that side. As previously we had quite a big enabling and decamp program on clearing the site. That was sort of slowed down during the review, and again on that side we're really going at pace now as we put all those moves around to make sure that the site is cleared. So that's working its way through, and it wouldn't be an outline business case in line with the sort of Treasury's Green Book unless we did all the paperwork associated with it as well. So we're updating all the trust strategies, and again working in partnership with everybody, because I know Keith's on the agenda later, how we're tying together with the neighbourhood hubs, etc., to make sure that the hospital is right sized. So hopefully that's the key headlines, and I'll pause there, Chair, for questions.
Thank you. I've got a couple of questions, and I'll open up to if others on the committee are interested. So first of all, again, thank you to you and your team for all the work you're doing on this, and also the work of getting us into wave 1, which is super important, because if I'm right, that's the only wave that's got actually money committed to it. So, which is majorly important when you're dealing with government, of course, because if money isn't committed, then there's more chances of obstacles being thrown in. The first question I want to ask, which is possibly a difficult question to answer, is this it now? Because I see in the papers we're at stage 1, and that's fantastic, but we've been taking 7 or 8 years to get to stage 1. So is this stage 1 for real, in the sense that actually this is the for real process ending towards the sort of construction beginning in 2028?
I mean, that is a sort of, if you cut to the nub of delivering the hospital, the process we've been through, it could feel, and I'll apologise for it, that we've gone back slightly a stage, because we had previously a design endorsed by the new hospitals programme and full planning permission. With the mandated piece now about being Hospital 2.0, we have had to go back slightly in the design stages, and what we're trying to do is we've done REBA 1, REBA 2, so that second stage we will complete by spring, and then that bigger detailed stage of what's called REBA 3 over the summer. So in terms of answering your question, hopefully, will be probably back to a position slightly more advanced to where we were previously by the summer this year. I think the key piece in terms of is it actually going to happen, having the letter of confirmation from the Minister for Health of the funding, and as you say, actual real money, so the money is there in the Treasury. Very much there is a push by the current government to get the hospitals built in wave one. So again, there's big political support and a big piece around London and everybody in Hillingdon wanting to make sure it happens. So we've got the sort of power in our elbow to do it. And then that other element of getting the builder on board. Once you've got a builder on board with their they've got reputation at stake as well, they'll want to make sure that they finalise the design with us and make sure it gets built as well.
So that's positive, hopefully. My last question is purely to do with the timelines. And this probably is my misunderstanding. Full business case submission in 2028 and construction begins in 2028. That feels radically quick for this sort of process that we've been going for. Why is that possible?
So, in terms of, I look at people's faces, experiences in sort of major business cases being approved by the centre. Sometimes it could be characterised previously as quite a lengthy process. I think what the commitment from our colleagues at the Department of Health and NHS England as part of the new hospitals programme is they really recognise that. And so what the process now going forward is, it's not as just handing things in and they're seeing it for the first time. So the outline business case that we're developing at the moment is co-designed, everything's worked up with them. So they're a member of our redevelopment programme board. If you look at all the workstream designs, everybody's sitting around there, all their commercial leads are involved. So actually when the outline business case goes in, it's pretty much both sides working together throughout the process, so they know what's coming and they've almost endorsed it by being involved in it, and it will be the same with the full business case. What we just need to ensure is that we're absolutely at the top of our game, so we have covered everything and there aren't any sort of serious questions. So the key thing is, if we do it really well, we won't go through that long process.
That sounds good. Let's hope. I'm sure your team will do it very well. So let's hope the government are as interested in that pace as well. Councillor Bells, did you have your hands up?
Yeah, just thanks for the tour that you gave us the other month. That was very enlightening and interesting. I wonder, you spoke at the time about the staff car parking situation. Were you able to update us on that at all? As you said you was close to being able to. Are you able to?
Very, very poignant question. So for anybody who walks around the site currently, if you look at the area to be developed, we pretty much have plans for all the services to move around. The key element that we need to work through is the temporary car park off-site. So for our staff car parking, during the transition whilst we're building, we'll move off-site. Patient car parking will stay on-site. On the staff car parking, we were very close to securing an arrangement with Brunel to look to secure land there to put our temporary car park. As it currently stands, I am less confident that that is going to happen from latest correspondence from Brunel, and indeed if that is then properly confirmed that that is no longer an option that they'd like to pursue with us, then we will go back to our original plan, which was slightly down the road at Moorcroft Lane, and develop that site. But it will be unfortunate if the Brunel option doesn't materialise, because from a staff perspective it would have worked really well.
Thank you. Councillor Martin.
Thank you, and thank you also for the tour. The summer seems a long time ago now when we completed that. I asked this question on behalf of the residents who've lived probably for a decade in hope of a new hospital at Hillingdon. And obviously there was a change of government in 2024, so we were one step forward, two steps back. We've edged forward with a new plan and you're resubmitting all your strategies. 2028 to begin the build takes us dangerously close to another possible change of government or change of leader, we don't know. How do the timescales fit? How secure are we to the exposure of a change of government and a change of policy? Because 2028-29 is when an election will be called, and it's not going to be ready till 2032. Thank you.
Very good question in terms of if you look at long-term programme management, it is at the mercy in some ways of political cycles. So you're absolutely right to call out strategically, probably the best thing that we can do is make sure that when we've got that builder on board that we start main construction before the next general election.
So, sorry, excuse me. So if construction has started in 2028 and obviously budgets are committed, then we are less likely to see a change of strategy at that point. So we're quite secure. So I suppose all eyes are on 2028. Thank you.
We can help with the bulldozering. But yes, no, super important. Okay, right. Are we happy to move? Oh, Councillor Smallwood.
Chair, just for clarity, are we just talking about the rebuild now, or are we talking more generally about the report?
So we're just talking about the rebuild, so Jason's now going to give us an update on Hillingdon Hospital's
I don't have a question on that.
Yeah, of course. Come to you.
Yep, apologies if I didn't make that clear. So, just in terms of, there's a second report in your papers, which is the sort of the trust overall headlines. I mean, from hopefully for people who have been using or working with people in the hospital this year, there is probably it feels like there's a sort of a palpable difference now in terms of how the hospital is operating. So if you look at the quality, I think if you look at some of the key headlines recently, there's really good improvements on the quality side. And I think, gosh, in October we sort of had a CQC inspection when they came back just to look at surgery and urgent care. That report is sort of in draft format, and so probably will come out in the next few months. And again, I'm hopeful on that. It will really sort of show that we are making good progress on the quality side. On the performance side, gosh, a scrutiny committee, it's probably a number of years since we've said Hillingdon Hospital is pretty much there on emergency and urgent care. And again, if you look at Alan, who's this year as Managing Director, if you look at the work he's been doing with Leslie as the sort of Chief Exec across in empowering the clinical teams, our urgent and emergency care, if you as sort of highlighted in the papers, is sort of getting up there in the sort of top of the pop stages in terms of, wow, in London and nationally, people are really noticing. So there's a huge well done to all our staff there. Again, with that, probably at previous scrutiny committees over the years, although nobody quite understands NHS accountancy, people have sort of raised concerns about the financial position of the trust. What's highlighted in the paper is we are on a £1.5 million deficit in the first 3 years, but that's on plan. And if you look, because that's just the way the savings have been profiled. And actually, where we are now is we're still on track to deliver a balanced financial position. So good on performance, good on the money. In terms of the workforce side, we've just finished our staff survey, and we'll be getting those results back. But again, if you look at our sort of how people are feeling empowered, people are actually really getting on and delivering. If you look at the levels of care to patients at the moment, I think it is markedly changed. So performance, finance, the workforce, all sort of working through at the moment. So I'll pause there, Chair, but hopefully people are seeing a really sustained improvement in services.
Excellent. So, I'm going to ask one question before I pass over to Councillor Smallwood and other councillors who want to ask questions. So, I think that is really positive, because for many years now we've had, good words and good direction of travel and some pockets of, good stuff happening. But this is the first time really we've got a report where some statistical evidence is being shown of improvement, which is actually really superbly impressive from what we've seen in the past. So I do really appreciate that, and I'm, hopeful that this will continue. So, as it's a scrutiny committee, I'm going to pick out probably the worst statistic in the whole of the report. So, on the NHS oversight framework, on the rating sort of structure there, they've got 1 for high, 4 for low, patient safety is 4. Now that is, I was reading these papers somewhere with, and someone said, what are you doing? I was talking to them about it. I said, by the way, you might want to know this if you have a choice between Hillingdon and Northwick Park. And I was, I'm very supportive of Hillingdon Hospital, but somebody who sees that is going to really ask questions. So can you talk us through that rating?
So, in terms of the sort of new NHS England, so they're the sort of main body who sort of oversee all the NHS trust providers in the country, what they've sort of put in place is, as you say, sort of just a very simple rating for hospitals throughout the country. And with that, it just, from a patient and local population perspective, does give you that sort of competitive piece of how good is your local hospital to the hospital down the road. The element you sort of are referring to on patient safety is probably affected the most by infection prevention and control. And your target for that is somewhat related to your previous years, because that sets your target. But that's not an overall excuse, hopefully, that I'm giving. We have really then now put in place, so if you look at Sarah, our chief nurse, a really sort of comprehensive programme to address some of the issues highlighted on IPC. And if you look at our monitoring in our sort of quality latest figures, the issues around IPC are coming back to where they should be. So again, huge amount of work by our clinical teams to address those issues.
I mean, I think it's really important we see movement on that numbers, because to be quite brutal, those numbers just to me, unavoidable deaths might be happening. I mean, that's the brutal end scale of it. But if I was looking at this in the same way you look at an Ofsted rating for picking a school, that would seriously put me off the idea of going to Hillingdon Hospital, because obviously after sort of expertise of medical care, patient safety is probably something that people look for most. But this is definitely something I think we want to sort of continue monitoring, and hopefully those improvements you're talking about will help get a better score up. Thank you. Councillor Smallwood.
Thank you, Chair. I'd like to talk about the Urgent Care Centre at Mount Vernon. Obviously, there was no meaningful public consultation with the public. There was a round table meeting where a few select people were invited, along with the Member of Parliament, David Simmons. I just wanted to understand how the data in here is gathered, whether it's patient-focused, staff-focused. I didn't really understand in a great amount of detail how the data was gathered, and also, since the closing of the Mount Vernon Minor Injuries Unit, I have spoken to multiple people who have filled in David Simmons' health survey that have said to me, having experienced short wait times on appointment at Mount Vernon, they are now sat in Hillingdon Hospital, and when they go there for their urgent care for a longer period of time, which doesn't seem like it's reconfigured extremely well.
So in terms of the consultation process, I can't answer you exactly what the process was, but I think it went through with all partners in line with due process, and I think the MPs and everybody was fully sort of involved in that. In terms of waiting times, I think the model that you've got at the Urgent Treatment Centre at Hillingdon Hospital, the overall performance there is being closely monitored, and actually, although attendances have gone up, which you would expect with the Hillingdon, Mount Vernon people coming over, performance has stayed on a par with what it was previously. So if it's useful, we can share some more data with you just to highlight, or hopefully give you the assurance you require, that in terms of waiting times at the UTC, the Urgent Treatment Centre at the Hillingdon Hospital, it is performing relatively well at the moment.
So, Jason, I think there is a lack of faith amongst a number of people, a big number of people, that actually this move is a good move. So any data that can be shared to tell the story of what's happening would be super useful. So obviously if you have it, do share it with Nikki so she can share it with us. Councillor Small, do you want to come back?
Yeah, I mean, I'll be celebrating when the Mount Vernon the Hillingdon Urgent Care Centre is performing at the level that the Mount Vernon was. That would be an achievement, and when you can come here and tell me that, I'll shake all your hands and say thank you very much, because I think that's where we'd like to be. I'd just like to reference a letter that was sent to Matthew Swindles, who is the chair in common of the Hillingdon Services Trust, by David Simmons, and it's in response to a letter that he sent him around the Urgent Care Centre, and it says, "I'd be interested to learn more about how the patient experience data is being collected, anecdotal feedback he has received from residents who since the end of September have used the urgent care and A&E in the Pembroke Centre suggests that those services are not sufficiently filling the gap left by the closure of the urgent care centre." I really would like to press you to understand how that data is gathered, how we can hear more about it, and how we are not going to... It's great to hear that the Hillingdon one is still performing, but I'd like to understand how we are going to get the Hillingdon one performing to the level that Mount Vernon was, because despite there being politics involved in this, the one thing is absolutely undeniable by all of us was that was one of the top performing urgent care units in the country, and the NHS staff there have my absolute praise and thanks for the incredible job that they did to perform there, and it has been taken away, and residents are rightly very, very, very cross about it, before unfortunately I feel something has been put in place. It's like buying a bunch of wagons but buying no horses, right? You tend to buy the horses first.
So, absolutely, if there's sort of further assurance you require, and I'm cognizant, as you say, that the MP has written to the chair of the 4 acute trusts, so just in terms of context, in North West London, all 4 acute trusts have the same chair, which is Matthew Swindles. In terms of that correspondence, my understanding is some data has been sort of shared in terms of sort of friends and family and other indicators. But again, in terms of the chair's point there, if we could maybe follow up outside the meeting of let's go through what data sets we've got that would share to give you that assurance.
Yeah, following up with data is a must, I'd say, on this. Thank you. Any other questions for Jason? Councillor Punja.
Thank you, and again, thank you for the visit, because that was really, really good for us to know how the build was going to take place, and also the design element of what was going to happen at the hospital. I would actually like to follow up on what Councillor Denys is asking about in terms of patient safety, because in paragraph 2 there, you're talking about quality and safety. There are an increased amount of falls, and I just wanted to understand whether the hospital knows what those falls are around. It says like there were 47 recorded inpatient falls. This is an increase from the 33 reported, and just kind of because of the nature of the falls, and especially with the relocation of services that are going to happen within the hospital, how is that kind of mitigated as well?
So in terms of some of the clinical moves, that doesn't sort of so much directly impact on the inpatient ward. So if you're, for those who haven't had a tour, please let me know and we'll give you a tour. But that sort of the nice big sort of 1960s architecture building is where most of the main of the wards are. If you work through that about what the key sort of reasons behind falls are, what will probably be required, because it's probably best that I don't answer it now, we provide you just a detailed breakdown of the types of falls, the learning. So again, whenever there's something like this, we have systems that you report on, and then you have to show the actions you're taking and the trends. So again, if that's okay, we can provide the data sets with you in a bit more narrative.
And just to comment, actually, that I would like to congratulate the new administration of the hospital, as Chief Executive and the Chief Managing Director, on the actual performance, of operational performance, because it's really good to see these statistics come in here after being on this committee for a couple of years now and being talked about, and it's just great that we are actually achieving something, and financially as well, because we knew what financial state the hospital trust was in. Thank you.
Thank you. Great. Excellent. So if that's everything on Hillingdon Hospital, then I'm happy to move on to the next agenda item. Not next agenda item, sorry. Everyone's getting too excited, including myself. That's probably due to having a bit too much cake. The next group of people within this agenda item. So Keith Spencer from the Hillingdon Health and Care Partners. would it be appropriate to have you, Sue from the ICB and Dr. Ritu Prasad from Hillingdon GP Confederation sort of talk together about what's happening, because you're all sort of linked? Does that sound good? So Keith, you can lead this bit of the meeting.
Thank you, Chair, and good evening, Councillors. As you just said, there'll be it's like a 70s pop group here. There's a trio of us who will be performing on this one. So what I'm going to do is we are heavily in the middle of our place transformation programme, and I can't let the last agenda item go without stating the important link between the work we're doing in out-of-hospital care. Remember, the focus of our transformation programme is to reduce the number of people who arrive at the ED department and to discharge people as quickly as possible from hospital. So I'm going to report on three main areas: integrated neighbourhood teams, our reactive care programme, and then best start in life, because obviously we're focused on children and families as well. So overall, hopefully as the report gets across, we are seeing meaningful progress in terms of what we're doing. What I would say is all our activity, all our metrics are rooted in the hospital redevelopment programme. So every target we have is what enables us to build a hospital which is fit for purpose. So if I just pick up first of all in terms of ED, I mean obviously our neighbourhood work and our reactive care work is intended to keep people safely away from the hospital. And what Jason has reported, currently our target is to get to no more than an average of 164 ED attendances per day to meet the hospital redevelopment target. As of last week, we hit that target, 164. To put it into context, that is a 5% reduction in ED attendances compared to the same winter period last year. It is the lowest in North West London. We are the only borough who showed a reduction in ED attendances in North West London. So I think it's just worthy of noting that effort in terms of a place contribution to that. There are also early signs of improved hospital flow, notably a 27% reduction in the number of patients without criteria to reside. These are people who are medically fit to be discharged. Our target is to get that down to 34. By the middle of November, we have that to 35. That is an ongoing challenge. It's an ongoing battle that we have to do. But again, a lot of work's gone in through the hospital and place to get those numbers to where they are. So we're not declaring victory. It is 3 years before the spade goes into the ground for the new hospital, and we have to operationalise and sustain that level of performance. So all three neighbourhoods are now operational. Frailty case management, we're now covering, so we have around 10,000 people who are severely frail in Hillingdon. Enhanced case management, which is really the only known effective way to keep people out of hospital, now covers half of that cohort, and our target for next year is to get that to 10,000. Is to increase it by a further 50%. When patients are under enhanced case management, their non-elective admissions reduced by 36%. So it's a significant impact, and the reason why we want to get that in there. Our hypertension case file has expanded. We've gone for, that's our major target, health and wellbeing target across Hillingdon. We know that if we can get our 24% of people with hypertension identified and 80% of that 24% on controlling their blood pressure, it will give us a 30% reduction in non-elective admissions to hospital. So the long-term plan, we've now got it to just under 14%. Our target is to get it to 16% next year. The best start in life work, we've started on a new child health hub model. Our mental health support in schools is expanding, and we've now got that to 80% coverage in terms of mental health support team working in our schools. In terms of what I'll focus on, if I may now, is what we're doing, what's gone live this month, and focus on reactive care. The reactive care programme strengthens urgent and crisis response in the community. So what this is intended to do, it's the hinge between neighbourhoods and hospital, and it responds within 2 hours to a crisis to keep people at home who otherwise would have gone into hospital. And we're doubling the capacity of that service from 3,500 referrals a year to nearly 7,000 referrals a year. We're supporting it with a senior clinical decision maker who's a GP, 7 days a week, 8 till 8, and that allows that team to hold more risk, keep more people at home. The new coordination hub will launch this month. Last week we started mobile diagnostics and providing x-rays for housebound and frail patients, and I had to give you a story to bring to life for you, and just picking up the Mount Vernon discussion, I think one of the patients was in the north. She lived in a second floor flat, and we took the x-ray to her. So that's the whole process of neighbourhood health, is to bring...
Sorry, Keith, to interrupt. That's super impressive, but how many people have this service? I mean, having it at all, I'm impressed by, but if it's only, let's say, 5 a day, that's a bit different from 20 a day. So how many people have that service?
So we're starting that as a pilot, looking at frailty. What it will do in the first... We'll monitor this in the first month. It will do, I think, up to 5 a day.
5, up to 10.
Up to 10 per day. When we demonstrate that it works, as we believe it will work, then we'll scale it. And I think that's the thing that's important. And we took last Friday, we basically visited, I think it was 4 or 5 care homes, and again those patients would have gone to hospital. So it gives you a sense of the transformation that's taking place in terms of what we're trying to deliver. So again, community IV antibiotics has started. This was formerly a hospital. You had to go to ESTEC to get your IV antibiotics. We're now providing that in our northern hub, in Ruislip and so on and so forth. The Lighthouse Mental Health Crisis Service, this is our crisis service at the front door to ED. You know we've had a significant issue with people with mental health challenges coming to the emergency department. That went live in an expanded capacity last week, went up from 4 to 6. It will go up to 10 a day from the 17th of December. And then the final bit is, obviously, I've just mentioned our discharge pathways have improved with a reduction in no criteria to reside patients from 48 to 35. What I would say, that has consumed quite significant senior time to get those numbers down, and I think on another occasion, Chair, it will be worthwhile having a look at some of the detail of that, because obviously it's quite a complex situation there in terms of our approach to discharge. But I'm pleased that actually we've been able to reduce that, because it's been a significant issue for us for some time. What we're also looking at doing in January, we're committed to doing, is bringing together the integration of reablement and rehabilitation. That's quite a fragmented service at the moment, and we believe by bringing those services together, it will allow us to streamline the discharge process of hospitals. And then, again, just to pick up some other issues, again, I've mentioned children and young people. The Health and Wellbeing Board yesterday adopted that as a priority going forward. So it's going to be a major part of our work going forward. And again, I've just mentioned the point around mental health support to schools, and getting the mental health support teams to 80% of all our schools, again, is a major step forward. What I would say, Chair, is risks. There are significant risks to what we're doing. We are mobilising a significant transformation programme in the middle of winter. Now, you might argue, isn't that the best time to mobilise it? But actually, there are risks with that, because it is a significant challenge given where we are. But the early data, looking at September to end of November, demonstrates that we have reduced attendances, ED attendances at the hospital, and that's a significant achievement. So a lot of initiatives have gone live in the last month. A number of other initiatives are due to go live this month, and again, we'll keep an eye on that. The final point is about again, I think a degree of clarity in terms of development of neighbourhood hubs, I think, is probably worthwhile at this point. You will know that we've been accredited to wave 1 of the implementation of the neighbourhood health service. That's an incredible achievement. There's only 2 of us in 2 boroughs in North West London to do that. What I would want to stress is that is about the early implementation of the service model. The capital funding of 3 neighbourhood hubs is subject to a separate process, and at the moment no one is handing out significant amounts of capital to our 3 neighbourhood hubs. That's a process that we have to...
It wouldn't be NHS if such processes didn't exist.
far more diplomatic than but that's a process we'll work on. We expect to have the business cases developed by the end of March this year. The priority places to do that are in Ruislip at Pembroke. We think for Uxbridge, for our south west hub, that was likely to be the Civic Centre, and then for our southeast hub, the old Nestlé factory in Hayes. And I think that's quite an important. That's the focus of the business case, and we are working as a place partnership and with the London Borough of Hillingdon and the ICB in terms of leveraging that. But I wouldn't want to underestimate the complexity and challenge of that particular business case, because as you rightly said, Chair, NHS capital is not the simplest thing to work through.
And if I just might add, in your papers, under Appendix 1, so all the developments that Keith has been talking about, we've listed the investments that the ICB have put in year, so just for the committee's information.
So Keith, thanks for that. And I will, Sue, is there anything else you want to add from the ICB's perspective?
No.
Okay, excellent. I actually have a question for you after Dr. Ritu, so you'll have a chance to speak more. So, Dr. Ritu Prasad, is there anything you want to talk about the work of the Hillingdon GP Confederation over the last
I think Keith has just outlined what we've started. So the senior clinical decision maker has been provided by the Confed, and we've started this X-ray facility for frail patients initially, so that anybody who's housebound or who would struggle to go into hospital or is in a care home, that's the service we've started. And we're working with our Care Connection teams and our care home service closely as well, so that all of these tie in, plus we're increasing the capacity in our same-day urgent care hubs, which then reduces the admissions to attendances at ED, and our extended access hubs as well. And some of the things that we did take from the minor injury unit was the dressing element, so that we've added on to our extended access hub, so patients don't need to travel to the hospital for the dressing element. Obviously, we can't deal with the minor injury element at the moment, but this is work in progress, and I'm sure that with the hospital we'll carry on working with that.
Thank you very much. Keith, it's great to see the things that are happening, because obviously you've been coming to talk to us for as long as I've been doing this on the committee as well. But so the planning sort of stage for all of this neighbourhood, working, a couple of years ago you came and presented some sort of grand plans and strategy on this stuff. And it's actually great to see stuff happening, which is really good. Obviously what we want to make sure is that the stuff that's happening can be embedded, and the partnership model that we have in Hillingdon, which seems to me to be very strong, especially compared to other boroughs that I speak to, we have the capital funding in order to deliver that. And so I think it's really great that locations have been identified for the free neighbourhood hubs. Obviously one is already operational up in Ruislip Manor, so anything that we can do in order to sort of help get the capital funding for that, to carry on the growth of the sort of neighbourhood plan, just let us know. And my one question before I open up to other councillors on the committee is for you, Sue, actually, because it's about the merger that's happening on the ICB. So for those who aren't aware, which is probably many people, because hardly anybody knows what an ICB really is, so North West London ICB is merging with the North Central London ICB to create a new super ICB. I'm not sure super ICB has ever existed before, but the ICBs are really important because they're the ones who basically control a lot of the funding. They're the ones who, their processes control the enabling. And so do we know exactly what's happening in terms of how it's going to affect us locally? Because I want to make sure in Hillingdon, you can carry on having the freedom really to do what we need to do in place. And a fear in a merger, there's two fears. One is the process will be overly complicated, and the second fear is we will be so remote that we can't do anything because actually other voices will be stronger together. So do we know anything about how it's going to work in the merger in terms of affecting our ability to sort of fund and deliver local services?
Thank you, Chair. So the merger is going ahead with the plan for the 1st of April 2026. So it will be the West and North ICB and will cover the 13 local authority areas that are currently in North West London and North Central London, so the 5 in North Central associated with the 8 in North West. That also covers 50 neighbourhoods. So yes, it is significant. It's 4.5 million people. It is about following the national blueprint for integrated care boards that came out in about May, I think, somewhere between March and May this year. And that is to refocus the focus of the ICB on strategic commissioning. So you're absolutely right. The role of the ICB in understanding population health need, in associated financial planning and commissioning across the board against that population health need, and meeting the responsibility and requirement for reducing health inequalities. But associated with that, and in line with the NHS plan, working through how the ICB engages with those 50 neighbourhoods and the 11 local authorities, and that is all up for information and discussion through the next 3 months as we go from here today through to the full merger in April. So there will be some kind of engagement process with our local authority colleagues, because of course the ICB carries a range of statutory responsibilities alongside the local authority, and we do, you know, a range of, like safeguarding and SEND and those kind of things. So there will be engagement with our local authority colleagues, but also with our partner colleagues in health, social care and the voluntary sector at place. I think one of the things that is really helpful from a Hillingdon point of view is Hillingdon, and Keith, you didn't say this, I thought you were going to. Hillingdon Place is part of the first wave national neighbourhood programme. We are one of 43 programmes across the country, and the other first wave is the by-borough, so it is Kensington and Chelsea and Westminster working together as a place. So we in North West London have a very big influence and a big partner at a national level to shape what neighbourhoods and place needs to look like, and so bring the NHS plan a little bit to life and to start working through the kind of impacts and influences that actually a forward-running neighbourhood and place needs to deliver on as to meet the NHS plan. And one of our big, you get a theme here, one of our big real advantages in Hillingdon is that we are doing this exactly as Keith has said, in line with the building of our new hospital. So that whole national profile is really, really key in keeping Hillingdon at the forefront of how we develop and deliver neighbourhoods and place alongside delivering our modern hospital. And the ICB, the new ICB Western, so there aren't any boroughs in North Central who are on the first wave national programme. The two boroughs are, as I say, the by-borough and Hillingdon. So the new West and North are very aligned and key and important in making sure that the ICB supports Hillingdon on its national programme. And the executive team for North Central and North West, they have been through their consultation, and they are working through now as the new executive team in getting ready and pulling through and creating the new ICB, but really focused on neighbourhood and place in that creation of meeting our ICB blueprint.
Okay, well thank you for that, and it's something that definitely I'll take an interest and more of an interest in, because we have our North West London chairs a scrutiny committee meeting next week, and it's certainly the one word I might be able to get into that, and the one word I'll definitely get into that is how this should strengthen our good working practice here in Hillingdon. And definitely I think it's really good to hear about all those different levers and focus that we have. Yes, volunteer to show anybody and help anybody, and be the poster person for this stuff, which is a tactic that Jason has used for the hospital, I know, which is very successful. So, yeah, we've got a great story to tell here, and I'll be telling it. So, good. Councillor Smallwood, you had a question.
Thank you, Chair. It is concerning, I think, as the Chair has said, to not hear that capital funding is in place, given what I've said earlier on, but I won't dwell on it in the season of goodwill. So I'm going to talk about something that I think is incredibly positive. The one thing I've learned in politics is if some major change has happened and then nobody talks about it, it's probably gone quite well. And I think Pharmacy First is something that everybody can agree was a fantastic achievement of the last government, but even more an achievement of pharmacists and the health providers that actually delivered it. And I know it received cross-party support as it was rolled out in Parliament. Two things. What are we doing with our pharmacy partners in relation to urgent care and now where they and how they provide it? But also, what lessons can we learn from that fantastic rollout of Pharmacy First to be able to do that kind of prevention, that early intervention, to tell people that actually, you know what, you can go down to the pharmacy, even if you've got a minor injury potentially, and they might send for an ambulance, or they might go and get the X-ray machine, and Keith will turn up in his car and do the X-ray. I heard him volunteer. No, I didn't. How are we going to? What lessons can we learn from Pharmacy First here in Hillingdon and all across our trust to be able to deliver, to take that and deliver it as we do these three hubs and we do the more integrated care? Thank you, Chair.
Thank you. Sue, do you want to say?
Thank you. Yes, I couldn't agree more about the success of Pharmacy First. So we have 52 community pharmacies in Hillingdon, and in the period April to September 25, so all 52 have signed up to Pharmacy First. And in the period, so they started the sign-up kind of from January last year onwards. In the period April to September 25, we have had 18,000 Pharmacy First appointments, which is enormous. It's really, really excellent. We've got the little, again, in the very final slide, we've got a little detail slide under Appendix 3 for your information. There are a range of conditions that our community pharmacists have signed up to, and they are there. So kind of minor infections, and also things like infected insect bites, uncomplicated urinary tract infections, minor infections of the kind of thing. Emergency contraception, high blood pressure. There's a range of pathways that our pharmacists have signed up to. The other thing we are a vanguard in Pharmacy First is the UTC linked to Pharmacy First. So Jason has referenced it in your report from the hospital, but people who come into UTC and who could be quite easily seen at a community pharmacist are redirected to the community pharmacist, and so that has been really, really successful. Lessons learned. I think it is slightly early days would be my call, to understand what are the lessons. We're really just getting it embedded as a known service so that our communities know what they can expect from their community pharmacist. But I think one of our key next steps that we could be thinking about and should be thinking about as that it gets known and embedded is how they then further embed into their neighbourhoods. So that the community pharmacists know which neighbourhoods they're working in, and that those kind of conditions that community pharmacy is dealing with so well, they're not either needing to go to the hospital, but also they're not needing to go to their general practice. So they're the kind of condition, so what we don't want is people turning up to the pharmacy and the answer by the pharmacist is you need to go and see your GP. So it's embedding the services, making them well known to our residents and our public, and then making sure they're well embedded in their neighbourhood and linked into the wider services in the neighbourhood. So that if it's beyond what the pharmacists can manage, they are referring appropriately.
Great. So, some homework for you. Next time we meet in 6 or 7 months' time, definitely, if you could think about, what are these lessons that can be transferred over? Because I completely take your point, early days in that sense, but it's great to hear about that. Councillor Smallwood, yeah.
Thank you. Just to change the subject completely, and apologies, this is not an area of expertise, but it's something that jumped out to me in the paper. Children's neurodevelopmental referrals remain extremely high. I understand that some of the funding is possibly going to end. What work is being put in place so that we don't return to a large backlog? And should the funding not be recurrent and come to us, what work is being put in place? Because that's an incredibly serious issue, and it was one particular stat that I pulled out that was of concern to me and will be to everybody around the table.
Thank you. Yes, agreed. So we do have an increase of our young people, children and young people, on neurodivergent pathways, ASD, ADHD. It's not well understood. So Hillingdon is not different about this. This is a national thing. It's not entirely well understood why. But it's certainly something that all services are grappling with, and also our schools are grappling with. Young people particularly in mainstream school, children and young people in mainstream school. The ICB has put in, as we said in the investment, we have put in money across northwest London I think it's something in the region of 6.7 million this year across to help our community provider services who actually clear the backlog. And so CNWL are the provider for Hillingdon, who are working on clearing the backlog. And that is really, really important because waiting times are long. We have also funded support, which is a waiting well programme. So whilst people are waiting, there is support and services in Hillingdon to support families who are waiting. But that is no excuse for the backlog and the length of time that people are waiting. CNWL have started to pilot, as well as getting actual clinicians just to come in and additional clinicians to come in using the money to do the assessments and work through diagnosis. They are piloting a digital solution to see whether families can access a diagnostic tool online. And that will be, if working successfully, that will be a sustainable solution going forward. We can get CNWL to tell us a little bit more about it. They're at really, really early stages in that, and they are currently targeting it at the backlog alongside the clinicians' work. But I think it is something. Certainly the ICB is keeping a really tight eye on in terms of CNWL. We are focusing on it at our SEND executive. We keep it regularly reported at our SEND operational group and our SEND executive board. I'm sure the committee, the scrutiny, the select committee would also want to keep a really close eye on this.
So thanks, Sue. That reminds me, thank you, Councillor Smallwood, for pointing that out. That reminds me that a couple of years ago we did a report into CAMS and an investigation and recommendations, and I think at some point soon we should actually revisit the whole subject, building on what you were talking about as well, because for a long time the situation hasn't been satisfactory. So maybe when we come to our work programme we can look and see when we can give that the appropriate time for that. So thank you. Councillor Punja.
Thank you. I want to say thank you for the energy that you've brought today. I think it's absolutely fantastic to hear how place and neighbourhood healthcare is actually taking shape finally, because I do think, I agree with Councillor Denys, that this has been something we've been hearing about in this committee for quite some time without actually coming to fruition in the way that it needed to. I've got two questions here. One is around the business case. Basically, you've talked about a 5% reduction going to ED. I'm assuming that actually business case for health hubs is about reducing the amount of people going to ED. So what would it, across this borough, in terms of from north to south of the borough, what are we expecting in terms of that reduction in people going to ED, or how many patients are we expecting to go into those health hubs rather than in ED? And the second question that I would have is that in terms of the diagnostics, we had the mobile bus kind of debacle of Heathrow Villages, as we all know. How would that enable those mobile diagnostics to kind of ensure that those where we have less healthcare access, like Harefield, for example, and Heathrow Villages, how would that be prioritised and enable those patients to have better access to those kind of diagnostics?
Shall we answer the last question first, Richard, because you're in terms of mobile diagnostics?
So the mobile diagnostics is serving all the areas within Hillingdon, including Harefield, and actually tomorrow they're going out to Heathrow Villages as well. So they can move anywhere. So it's not just because their base is at Pembroke doesn't mean that they're not serving the entire population. So the referrals come in there, they're there. People who can get there can have their x-rays, but they are moving around all over the Hillingdon.
But have we learnt from the problems with the bus, the Heathrow Villages bus, which sound like a good idea, but to be honest, the implementation of it didn't work at all very well. So
it's not just one single bus. Literally, you can take it on a motorcycle as well if it came to that. That's the way they work, and they are very sophisticated. It's nothing like that bus that went out. That much I can assure you.
I think, and I don't mean to trivialise it, but it literally is like looking at the Just Eat. It is. We did want to call it Just Treat, but we thought we'd come into serious copyright issues if we did. But it's that small. It literally is that small, and our belief it's a game changer in terms of the sort of hospital to community shift. And it's not just X-ray. If this works, we'll scale it. We can add ultrasound. We can add fibroscan, all the things that you would wait quite a long time for at a hospital. So to us, it's quite important. The first question, one of the things we're literally doing at this point in time for the business case is assessing the volumes that are going to go through each hub. And it's slightly more complicated than you might think, because you'll say, well, don't you know how many? The conversation we're currently having with our colleagues at the hospital is with the hubs, and with the technology we'll be able to deploy there, what sort of service is currently provided in the hospital could we actually just change and deliver each of the three hubs? And that's quite a difficult algorithm, just to try and translate that into that capacity. That's the bit of work we're doing now. We know community nursing capacity, we know how many mobile diagnostic capacity we can do. What we're just trying to quantify is what those re-provided services, what that might look like. But we're very close to that. We'll have that work done in the next month, so we can circulate that information. It's a key part of the business case.
Oh, yeah. One more? Yeah, go for it.
And so I'm assuming that will then relate back to the hospital in terms of kind of like the waiting times that we're talking about, and kind of like that increase in those ratings, and hopefully the kind of 1 to 4 going in a better direction in terms of your kind of scaling or outcomes driven. But I also want to kind of think then about, because in terms of the redesign of the hospital and what you were doing with urgent care, you were talking about having different kinds of triaging spaces in the hospital as well. And how will that impact? Because you're talking about what you can take out of ED to put into mobile diagnostics, but then where does that come into the triaging, and who's doing the triaging at which point?
So, as part of the model that we've developed in terms of what we call reactive care, there's something called the coordination hub, and the best way to think about that is as a brain. And what it's doing is acting as the air traffic control for the out of hospital urgent care, and it is doing the triage in terms of care home. Let's just take an example of a care home resident falls. What would happen now would be 999 would be called, the ambulance would call, and without any shadow of a doubt, that person would go into ambulance and will be in the ED department within about an hour or so. By developing the coordination hub, there would be a direct link between the ambulance service and the coordination hub, and actually there will be an ongoing dialogue and conversation about what the best pace of deployment is. So what's being built across North West London is a link between the ambulance service, the coordination hub, and the hospital, so that if you imagine it's a three-way dialogue all the time, which we don't currently have. So what we're trying to do is, in a out-of-hospital setting, is get better coordination of when urgent care is required, of sending the right clinician to see the patient. At the moment, it's all individual services. And what the ambulance trust will say, well, what's available.
I mean, that is so important. That is so important. Again, there's another NHS story of people see one NHS and they probably know about urgent care, and in the hospital, and they probably know about the GP, of course. But yeah, we or you have to be able to get that pathway correct. Otherwise, everyone will just go to the GP or to the hospital. So, are you going to give us positive news about that pathway being created?
Thank you. Yes, just in conjunction with that, we already this year have put into place what we call same-day emergency care pathways between the GP and the hospital. So we have a range of units in our hospital: surgical assessment unit, medical assessment unit, frailty assessment unit. There's 3 or 4 of them. Jason will tell me more, I'm sure. And we have worked through, Ritu, you've been instrumental in this from a clinical point of view. We have worked through referral pathways so that if a patient is seen by their GP, the GP does the triage. This happens right now. The GP does the triage, and actually, having done the clinical triage, is deemed to be a trusted assessor, a clinical trusted assessor, but it's beyond what the GP can manage in their GP practice. The patient needs more of an emergency response that only the hospital can give. And rather than sending the patient to ED, the GP, having done the assessment, sends the patient directly to the appropriate unit, and the clinician at the appropriate doesn't have to reassess the patient because the GP has already done they just get in. And so it used to be that in order to access all those emergency same-day units, everybody had to come via ED and have an assessment in ED by the emergency team in ED, and then go and have an assessment in the same, and that is actively reducing, and people are coming in straight in from their GP. That is happening now.
Thank you very much. I'm going to move on now, because like always in these meetings, this is absolutely fascinating. We could have an hour just on that, but we'll come back to that with other questions in the future, because yeah, that sounds like a really great initiative. But I have Councillor Chamdell, Councillor Bells and Councillor Martin who want to ask a question. So Councillor Chamdell.
Thank you, Chair. This is come back to pharmacy first and more for Dr. Ritu Prasad. So with the pharmacy first, has it had a positive impact on the number of patients requesting GP appointments? And I can't remember if we discussed it before. Do pharmacies prescribe antibiotics? Okay.
They are able to prescribe antibiotics under this new scheme, and that's why it's changed the game. I mean, it's been you've seen the positive response, because previously they used to go and be assessed, and if they need an antibiotic, back to the GP, while for these 7 conditions they're able to do that. So yes, it hasn't had a positive impact for GPs as well, because then you can deal with more complex patients, and that's why. So it all has a cascading effect, because if we are able to manage complex people, they're less likely to go to the hospital. So yes, they are able to prescribe antibiotics. So that is a positive thing.
Just one more question, Chair. So are patients still struggling, though, to get appointments, or is it getting better?
So appointments will never be enough, to be truthful, but yes, it's improved the pathways, definitely. And with online consultations and also triage, that has helped. It is difficult to change the mindset in people, and for patients to accept pharmacy first as an option has been a struggle, but now they're getting used to it. And I think when they see that this can be dealt with at my local pharmacy, they're less likely to repeat that and ask for an appointment. Some do come back, which is fair enough. If the pharmacists feel that they need to see a GP, that's absolutely fine. But we have a good relationship with our community pharmacists. So in each PCNs, we've got a relationship with all our community pharmacists. One of them is the lead. So we have these conversations and how can we improve the pathways. And so we are not ping-ponging patients backwards and forwards as well. But it will change as it embeds in better.
Thank you. Just an example, it's pleasing to see a positive response, because I think we've challenged GPs regularly. And I had a recent experience with a GP, and I was really pleased, so go back to your confederation, the work that you've done, that we got a call within 24 hours and was prescribed antibiotics over the phone. So that's really pleasing. So it's good to see some good coming out of the challenges. Thank you.
This has been a really positive meeting so far, which is really good. Lots of good stories and lots of good progress. Yeah, no, really good to hear. Councillor Bells, are you continuing on this track, or are you going to throw a grenade in?
Just as a side, I was in my pharmacist this morning, and 2 people came in for pharmacy first consultation, so it was just happening there and then. So that's happening well. But just a question of, we're told that flu's come early this year, and it's affected. Has it come early to Hillingdon, and how are we coping?
It has come, and it comes in waves. I think 1 week is worse, and then the hospital gets the brunt of it because there are some sick people. Yes, it has come early, and people are pretty sick, and it's prolonged as well. So the virus that's going around, instead of like 5-6 days, you're fine. It can take up to 2 weeks.
Are we coping okay as a borough?
I think so. I think we are.
We are coping. I would suggest we are coping better than any other North West London, but the data tells us we're coping better than any other North London borough.
And our vaccination rates across the cohort is generally higher than other boroughs in North West London.
Thank you. Councillor Martin.
Thank you. A lot of what you guys talk about with the different hubs and the different facilities and the joined up healthcare is to keep the pressure off the emergency department, keep the pressure off the hospitals, because once people get to the wrong point, you can't get them back out easily, and that seems to be sort of the focus. For example, of the 160 or so people that present at the emergency department at Hillingdon, how many shouldn't be there, or could, in a nicer phrase, how many should be on a different pathway to the pharmacy, the GP, an urgent care centre, if there's still one that's open near them? What sort of numbers, if you're able to share, that could be on a better pathway?
So, I think what we've done remarkably well is if you look at the numbers, is shift the balance between people going to ED who should be going to ED. And if you look at the UTC, go back to the start of the conversation, Alan McGlenn, who's Chief Medical Officer and Manager, tells us that if you look at that cohort of 200 people every day who go to the UTC, about a third probably don't need to be there. And that's the cohort that we are collectively now going after. Please don't get the wrong message from that. We're not physically stalking people. But that's the cohort we need to try now and tackle.
So of those 50 or 60 people that have presented at the wrong place, what's the ethos for re-educating? Because as a member of this committee for the last year and a half, 2 years, it's really complicated, some of the methods we have for healthcare. The average person who walks down the high street or who wakes up tomorrow morning who's not well would not know there's a joined up health hub there or an urgent care centre there. They're just going to go to the nearest one they can get on a bus and get to it. So we need to educate, and we saw some evidence, didn't we, of what the impact Pharmacy First can have to reduce that. So how can we educate the general public, and how are we? Thank you.
So we discussed this at Health and Wellbeing Board yesterday, and I think what we have to try and do, what we haven't done well enough, is engage with the public and educate them. So we've done a couple of events in the last 2 weeks where we've had really good turnout to talk. When you talk to people about hubs and what will be available, their view is, well, that's good, isn't it? They need to know about it to be able to do that. So I think you're right. And one of the things we're going to do in January and February coming up is on the back of the health and wellbeing strategy, which our Health and Wellbeing Board approved in principle yesterday, is go out and engage with the public in each neighbourhood about what is available. And I think what we have to learn, and I'll speak now from health services, I think we do have to be more assertive in terms of what people's personal responsibility actually is going forward. So I spent a lot of time in the last month or two looking at discharge, and I think one of the things that we try and do often is sort people's lives out for them, and that's not the responsibility of health to sort someone's life out in terms of what they do. So I think there is I think Alan McGlennon yesterday called it, we need almost a social contract with people about what their responsibility is, but it's incumbent on us then to say, here are the alternatives, this is what you can do, and we need to do that better. And there's a real big engagement piece there I think we haven't done that we need to do.
Yeah, and the triaging is really important in this as well, to be honest, as well, because as Councillor Martin says, you've got the urgent care, Hillingdon Centre, and then you've got GP. That's for most people their world. But obviously if my GP told me, or actually I could be seen 3 hours quicker if I went to something else or did something else, then that's what people will choose. Okay, so I'm going to move on now to the last person on this agenda item. So Dr. Richard Grocott-Mason from Royal Brompton and Harefield Hospital. First of all, welcome. This is your first meeting with us. Apologies that you're last person and it's gone on longer than I thought it would do, but always with health you can just dive down so many different routes. My promise to you is next time you can go first. So that apology and that promise. So please, could you just give us an update on what's happening with the Royal Brompton Harefield Hospital?
Yeah, no, thank you very much, Chair, for the invitation to come and attend. I'm Richard Grocott-Mason. I'm a cardiologist, and I'm Chief Exec of what we call the Heart Lung Critical Care Clinical Group of Guy's and St Thomas's, which includes Royal Brompton and Harefield Hospitals. And again, I don't know how much colleagues are really aware of the unique place that Harefield is, but we don't have an emergency department, but since 2004 we have had the first and one of the busiest heart attack centres in the country. So patients with a heart attack are taken there directly by the ambulance to Harefield. We've got a particular interest in cardiogenic shock, which are the most serious patients with heart attacks. The other services that we provide, cardiac surgery, thoracic surgery, and the heart and lung transplant service. It'd be useful to get feedback on the report, whether this is useful format and information that you would like to see. To highlight a few elements of things, it's a really difficult environment at the moment, and there are some real challenges in healthcare, some of which we've been talking about, and some really positive developments, but there are lots of challenges, and for us those challenges relate to waiting times for cardiac surgery, much longer than we would like them to be, and have not really recovered to pre-COVID levels. Issues with meeting the demand for lung cancer treatments, which is a good news story in the sense that there has been a real transformation in earlier diagnosis of lung cancer and treatment options, but that means that there's a growth in the demand for services and more patients are suitable for surgical treatment, which is potentially curative treatment. That puts a challenge on meeting the 62-day pathway for treating patients with lung cancer, and so that's an operational focus for us. We don't have the 18-month waits for patients, but quite frankly, for many of our patients, 18 months is not an appropriate time to be talking about treatment. We have far more patients who are in the category of really needing treatments within 4 weeks, not emergency or in-hospital treatment, but elective treatment within 4 weeks, and we're not able to deliver that for all of our patients. And in the grand scheme of things, there is no real prioritization of those patients in the current way that cancer and long-wait patients have priority. The transplant service is thriving. The last financial year, we did 62 heart and lung transplants. This year, so far, we're ahead of that number. We've done 27 lungs and 21 hearts, and Harefield has also just been announced as one of the centres that is what's called an ARC centre, but assessment and reconditioning of lungs, where the idea to try and increase the number of available lungs for transplantation. Lungs are brought to or will be brought to the hospital on a perfusion rig that enables the lungs to be assessed whether they are suitable for transplantation, potentially opening up research elements and being able to make more lungs available for those patients who would benefit from transplantation. I'll probably stop there in the interest of time. Happy to take any questions and any comments.
So, thank you very much. My only question really is about, obviously, the waiting times. Is that an issue to do with staff, facilities, or is it an issue to do with the fact that essentially there's so many people wanting the service that no matter what you do, the waiting times really are going to be hard to get down?
It's a mixture of all. The demand is high, and particularly the demand. So across London, there are more than 1,600 patients waiting for cardiac surgery. Across our clinical group, which includes cardiac surgery at Harefield, Royal Brompton, and Guy's and St Thomas's at the St Thomas's site, we've got something like 800 patients waiting. So we've got about half the London waiting list, and we do around about half, 40 to 50% of London's cardiac surgery within those three hospitals. If we had more resource, we could extend the operating into weekends and everything, but that's one of the things that is pretty challenged at the moment. And about a third of the work is non-elective work, where patients are constantly appearing at other hospitals and taking priority of clinical urgency. And so trying to get the waiting list down, we're in totality only able to really dedicate 2/3 of our overall capacity, because a third to a half is taken up with additional patients. Added into that some of the challenges that we've had around industrial action and things, it's quite hard to do that. We really need to get over effectively the COVID period, where there was pretty much a year where London's cardiac surgery reduced very significantly. To get that back and to continue the run rate, you need a 10%, 20% increase in overall capacity, and that's something which we haven't managed to achieve. I was going to say as well, just that might confuse people, we are part of Guy's and St Thomas's Foundation Trust, and as such we sit in South East London ICB, rather than, even though we're geographically obviously haven't moved from Hillingdon.
Yes. Oh, you're very welcome to come to our meeting, and I hope you don't have to trek over to not South West London's very nice, but the traffic isn't. Councillor Martin.
Thank you. I just want to share, I do have a small job at Harefield Hospital, so I've seen firsthand some of the work that's done at Harefield, and for such a small facility, it's remarkable how busy it can be. But you may have touched on it briefly. It also almost runs at school hours. And so in the evenings and at the weekends, the whole thing almost grinds to a halt, apart from emergency admissions. And I wonder if you touched on the resources. Is there anything you can do to help these lists to keep the cath labs open at the weekend or later? And sometimes as we run up to Christmas or into the summer months, it just goes spookily quiet for a hospital with these kinds of waiting lists, and there has to be more that can be done, I'm assuming, to use the great facilities that are there.
Yeah, it may appear quiet on the outside. It's pretty much never quiet on the inside, and particularly in the critical care unit, which has 24 beds of patients on various levels of mechanical circulatory support. There's 24/7 operating of both cardiac surgery, transplantation as required. I used to do the heart attack on-call service, and it can be operating all night with patients, depending on when patients come through. The outpatient service is, Monday to Friday, usually standard kind of hours. We do lists at weekends often, but again, that currently is because of the let's say the prioritization that's been given to making the financial numbers add up, particularly in the first half of this year. That's been difficult because there's an extra cost element, and also staff numbers. There's only so much overtime and additional hours that people can do, and some of the staff groups that we rely on are national shortage skills, and London is expensive, and it can be quite difficult to maintain full complement of staff.
Thank you. And one of the facts or the points that I pulled out here, it's a bit of a morbid one, is that it's a good one. It's a good one. The mortality rate at Harefield is 10 times more favourable than other hospitals. And I hear patients tell us that it's the best hospital. They choose sometimes to travel across the country to come to Harefield because it's always rated as the best. And I often joke that which one's rated as the worst if that one's the best, because obviously that statistic must exist if that's the best one. What would you like to tell us why Harefield Hospital just gets it right and has such good results?
Yeah, the number is across Harefield and Royal Brompton, and specifically about thoracic surgery, and we have a very big, very experienced thoracic surgical team, and across the Trust of Guy's and St Thomas's, about 1 in 6 of all of the lung resections for lung cancer treatments in the country happen in England. So it's a very big experienced service. I don't know what else happens in other parts of the country on that particular data from that. In terms of as I say, that statistic is specifically about the outcomes for lung cancer, and it's one of the things that we're trying to work on. Where, as I say, lung cancer is a really good health story that hasn't really had much in the way of publicity about the change to the targeted lung health screening programs, earlier detection, and more people being able to be treated. We tend to find ourselves in the naughty step because we can't manage particularly to get everybody through in 62 days, and again, as a trust as a whole, patients are coming in from maybe 20 or 30 different DGHs into that pathway, and for patients having part of their lung cut out, quite a number of tests and things need to be done beforehand. It's not as straightforward as some of the other cancer pathways, but still we're judged on the same metric, and that's been a challenge, and we're particularly focusing on how we get patients through that.
Great. So, Councillor Funger. Yeah.
Thank you very much. Previously, we had at this committee information about some of the buildings and kind of like the need of improvement of buildings. and also then there was about a recruitment drive and what the Harefield Hospital were doing about a recruitment drive. Has it all stopped now, or is there a pause? Is it stopped, or is there a new strategy around that at all?
Certainly around recruitment. Overall, the recruitment is pretty good, and retention is very good there. Often patient or staff come and never leave in Harefield, and so I mean it's an ongoing that never stops in terms of making sure that we're fully staffed. It is quite a unique environment for working in. As far as the need for redevelopment, modernisation and investment, absolutely that's something which we are working on, and we've had a number of plans and we've got a number of kind of options, but we've heard earlier on that the challenge involved in getting public money into doing that, and we think it is extremely unlikely that we would get any public funding into doing anything on Harefield site because of the money into Hillingdon, into Watford, into other sources of North West London, and all the pressures in South East London. So we're thinking about how we can meet that challenge.
Councillor Bells.
Thank you, Chair. Councillor Punjab basically asked my question, but as a regular patient at Harefield, as an aside, I've seen groups from America come round to visit the hospital and said as an aside, wow, how do you just achieve so much in these sort of conditions? It's fantastic what's done there in them conditions. So hopefully the tide will turn for you.
Yes, no, thank you. I mean, the hospital was built in the 30s for TB patients, and we've modified and adapted and remodified. It's tricky. I mean, the lack of capital investment into health facilities in general, as Hillingdon and everywhere else, is not something to be particularly proud of in the UK.
Thank you. So, okay, well, I'm going to draw this agenda item to a close. So, to our health partners, thank you so much for coming tonight, and you're welcome to stay, but also you're very welcome to leave if you wish to. You can grab some cake on the way out, actually, if you want to, because there's still some nice cake left. While we in the committee, we're going to move on to our second substantial item, which is the budget and spending reports. So, Sandra Taylor, would you like to sort of lead this item, and then obviously pass over to Matt Davis and Martin Story as you wish as well?
Certainly. Good evening and thank you. I'm just going to flick the paper from Harefield. Really, really interesting piece from them, wasn't it? So we're here to talk about adult social care budget, and colleagues from finance are here to support with this item. You will see that committee asked at the last meeting to demonstrate some benchmarking and to give you some evidence of how we perform against other local authorities. And I said at the time that the use of resources report was due. That report has come in. I would caveat, and I've attached as an appendix, I'd caveat that in the report it's got data that comes from ASCOF, which is the Adult Social Care Framework, that is out of date, and that is just that they put it in. The new version of the report is due next week, so I will refresh that with the committee as soon as it arrives with the updated. I know that our ASCOF data that's in that report shows a high level of residential placement. Is actually inaccurate in as much as it included long and short-term placements. It doesn't necessarily affect too much of the detail within the report, but just for your information. So it's a very pleasing report actually, and does demonstrate that we continue to be really good value, use our resources really well. We're low cost against our our neighbours and other London boroughs, which is important to know that we're actually using every penny we have, albeit very challenged in terms of budget, that we're using it well for our residents. So that's really important. When you look at some of the other data, you asked for some graphs and some examples. We've done, since the last committee, a huge amount. Martin and Matt and I have been working with another colleague, a huge amount of work on demand growth and inflation, so that for next year you'll see that we've had again this year a pressure on our placements budget, and that demand growth modelling that we've spent probably 8 to 12 weeks really honing and refining. We've spent a lot of time going through literally all the cases, all of the inflation. It's really been a difficult, tricky kind of 5-year period. As the doctor pointed out, COVID still plays a silly part in our data of going up and down, and if you do look at the graphs there, you can see that 23-24 in our primary support reasons, so that is learning disability, older people, physical disability, mental health, and things like home care, residential and nursing placements, you can see that data is still a bit skewed. We're coming out of that, and I would say I now have confidence in the older people figures in terms of our placements and being able to stabilise those numbers, and that is reflective of a lot of the work that the hospital are doing. So you see that whole system piece being picked up in as much as they have got through their electives that weren't done during COVID, where lots of older people didn't get their treatment and surgery. So they're getting through that work, people are being treated. So you see our stable position with older people services, where we're seeing that whoosh up the really strong demand line, and that is through our learning disability and mental health services. So we're doing a lot of work on our forecasting, our modelling, and looking at how we can try and understand where that demand is being driven from at the moment. We, again, health colleagues talked about the neurodivergent demand on services for people for assessment, and we're finding the same thing happening through social care. So I think that's the position. There's some significant graphs. The other one I just want to point out is as part of our inspection process, we would one of the areas for improvement was about improving the use of direct payments for residents. And if you actually look at our home care numbers, they're going down, and if you look at our direct payment numbers, they're going up, and that's both good value for money, and it gives residents autonomy to provide their own care and support and make those choices. So if you see one looking like that and one looking like that, that's good. That's a good thing. So I think if it's helpful, I can either take questions or hand over to Martin and Matt.
I think, Matt, do you just want to talk a bit about the numbers?
Thank you, Chair. I read the report prior to the meeting and have a few observations I'd just like to share with you. We're reporting at period 6 a 5.1 million overspend. Obviously, Sandra and the team are doing everything possible to try and mitigate that. If you look at the detailed schedule, there are lots of areas that are delivering savings or underspends to offset those. One of the things that within the 5.1 million, within the savings schedules, there are two numbers I want to highlight. Both are identified as a red risk. There's the renegotiation of a care contract. We're doing everything we can to try and bring down those prices, but recognise across the sector, with national insurance charges being added to employers, a rising elderly population, there is a growth pressure within the market across the country. That's 1.7 million. There's also 2.1 million, which is to do with trying to gain a fairer share of Section 117 funding from the NHS. Currently, I believe, Sandra, we receive 37%. Other boroughs across London or West London are receiving 40 or 50%. Sandra has been in negotiations for probably since you started in the role, or at least 2023, to get a fair allocation. No one's been able to tell us from the NHS why we receive a lesser proportion, and we are pushing hard to get a fair proportion similar to all the other London boroughs. Those two add to nearly 4 million of the 5 million gap in total. The other thing I'd like...
Matt, very quickly, who's responsible for that decision? I mean, who's deciding that we should get significantly less money? Who are you lobbying, Sandra?
The ICB.
Okay,
so
right, that's useful to know.
It's part of legislation that is under Section 117 in the Care Act in relation to mental health support services when people, it's aftercare when people leave hospital after being detained under Section 3. So we, nationally, there is a range of rates that are negotiated by local ICBs with local authorities, but we are the lowest in North West London. Our rate is the lowest and has been since 2019. I took this role in 2022 and in 2023 started renegotiation with other colleagues in North West London who have a variety of different rates, and we are in the process of speaking with the ICB who are now at the table with us, but it's rather late in the day. Has been very challenging to try and get engagement to get that discussed.
Thanks. Sorry to interrupt, just because that's such an incredibly unfair thing. I just wanted to get a bit more detail. Matt, do you want to continue?
I'd also like to just mention that if you're looking to make savings within a service area, I've worked in a number of councils where a target has been allocated. You can make savings or reduce pressures by either reducing your cost or increasing your income. If you add income to expenditure rather than netting them off, that's a potential for trying to balance your budget. If you've got £100 of cost, you've got £100 of income, your potential to make a saving isn't net naught, it's from the £200 of more of either or less of the other. If you add the budget for this service, comes to the income, 269 million. First table one, first column, you add them together. The overspend of 5.1 million is less than 2% of the budget that Sandra and the team are trying to control. If the pass mark for my O-level maths exam was 98% and I failed if I got less, I think quite a few people would have failed their O-level maths. Finally, this morning I did look at the comparative data for similar outer London boroughs. Sitford do a nearest neighbour list of 15 other authorities, and where I've been able to look at their spending detail for Q2, where they publish the information, I noticed that Ealing are overspending by 2 million, Harrow by 6.6 million, Brent 1.2, Enfield 5.3, Kingston 1 million, Havering 6.57, Waltham Forest 7.3, Bexley 3.6, and Redbridge, including public health, are reporting a 23 million overspend. The 5 million overspend within our adult services needs to be taken in context of the pressures that the service is facing, both locally and councils across the country are facing. Thank you, Chair.
Well, that's really interesting context. I mean, you know, when you read the report, you know, obviously it does seem to say that, and I believe it, that we're getting good value. We've obviously got a very good CQC rating, so we're delivering a very good service, getting good value. But yeah, no, we need to make sure that we're getting the funding we deserve in order to carry on delivering that. And I think it's really interesting about the numbers you just mentioned there. Yeah, I mean so I was not all the questions I had actually you've answered in your presentation, so that's very good. So yeah, I'm happy to open up to other people. So Councillor Punja, yeah.
Yeah, thank you. You have answered some of my questions as well, Matt, so I appreciate that. But one of the things that I am going to say in this is, whilst I appreciate what other boroughs are doing, we're in Hillingdon and we're in an exceptional circumstance here, and that is really important to recognise, because that's what we've got to deal with as residents, as council taxpayers, but also as an authority. So one of the things that I'm really kind of wanting, because we're going into the budget setting phase for next year, and something that is really important, I think, because you deliver an amazing service, Sandra. We cannot discount the fine service that you are actually delivering. We know that from the CCTV reports, but I know that from kind of having talked to you and known what the work that is put in, and from sitting in this committee. What I don't want to happen for our services is to be, last year we talked about transformation and that AI was going to solve all our problems, and we put budgets in that I felt weren't robust, if I would use that word, or kind of really modelled on real data. I appreciate that there's a lot of work that's now being done about that data collection, so that you are going to have potentially better forecasting models. But one of the things that I think might be worth having is like that variance between cost and budget, so that actually we know from month to month where those variances have taken place. Because moving forward, if you've got to go and say, right, next year I've got to make this much savings, how is that going to happen if we are still going to sit there and go, yes, you're right, 2% isn't much of a budget, but actually when it comes down to the outturn forecast of 9.8, that's nearly a third of what the total savings of the authority is supposed to be. So I think we've got to have that realistic conversation and look in terms of that analysis. And so really I kind of wanted to understand more about what's happening now in terms of the financial modelling for adult social care, so that we have got the data, so that we're not relying on playing the chart kind of like, AI transformation that hasn't been tested, tried, and we don't know what it was. And I remember saying that at the committee this time last year, that this has not been done before, what are we doing about this? And it was going to save everything, and it hasn't proved to be true. So, yeah, if I may leave that with you.
Sandra and Matt, unpick that and answer it.
I think we'll do a bit of each, if that's okay. Just in terms of AI, I do the first bit, because that's the straightforward bit for me. We have had some fantastic resource built into adult social care that we're piloting at the moment that is making a significant difference. So it's called Magic Notes, and it assists social workers in being able to undertake really good quality recording quickly, accurately. It does translations and it puts it directly into our system. And if anybody is interested in a bit of a view of something at some point, I'm sure, don't ask me, but one of the team would be very happy to.
But in all seriousness, Sandra, I think actually maybe for those of us on the committee who are interested, having a demonstration of how it works and how it's improved our processes would be really useful. So if you or somebody in your team can speak to Nikki and then open it up to us who are interested, because yes, this was talked about and you're saying, and I believe you, it's being delivered, but I think we'd like to see how.
It's literally just commenced its full rollout across adults. It will go to children's and hopefully send soon, but it will and is already making a difference. It's making a difference on a number of levels. It's increasing capacity of social workers, it's managing demand, and it's managing quality as well. So it's given us that better recordings, but everything that's in the system is accurate. So all round, we're not having to put extra resource into making sure that what goes into our systems is cleaned up, is accurate, is doing what we need it to do. So that's a real positive. It did deliver staff savings that were in this year's MTFS, and we consider that banked. So it was a real success story. It's the start of our digital journey for adult social care. There's a lot more that can be done in a number of ways around self-serve and residents helping themselves, but also using tech-enabled care and that kind of thing to enable residents. A lot of what I'm saying here is about managing demand more than it is being able to make significant savings. It's because demand is relentless. So we've got to find ways, and Keith touched on it when he was talking about health, about how we've got to help residents help themselves. Pharmacy First is a great example of that. We've got to help residents be able to help themselves with equipment, to know where to get their own equipment. We have a frontline on the website application called Ask Sarah, and you can log into, any resident can log into that and get an assessment of what they need in terms of adaptations to help themselves, and it will also take them to a website where they can purchase that or ask for a full OT assessment. So those are the positives. Those are the AI bits that are getting into play. But in terms of the funding and whether or not we have enough in our budget to meet need and demand, basically it comes down to two things. It comes down to the number of people coming to our door for services and the price that we're being charged by providers. And at the moment, price is outstripping demand. So you'll know at committee that we've taken steps to open the boroughs in our care company, and that we're looking to have more beds by building at the Lobster Pot car park in the future. And we're looking at whether it actually makes more sense for in-house services through our own care companies are more financially stable for us as a department to be able to manage, because it's a very busy care market in Hillingdon. We've got more than 1,200 nursing and residential beds, but we can't access all of those because it's cheaper to place here than it is to place in Kensington and Chelsea, for example. So those are the things that we've been working on. We've worked on, and rather than doing placements as a block of money, which is a big block of multi-millions, we've looked at each individual area, which is why you'll see the graphs in the pack, and we've looked at what the demand is for those areas, tracking back and tracking forward, and we've looked at 5 years on from now. So we've looked at the growth plus what we think the price is. It makes the growth look eye-watering when you actually start to look at the figures and the numbers, but as you rightly point out, I need to make sure that there is sufficient in the budget for me to be able to say this is what it's going to cost for adult social care next year, and if I then overspend on that, you can hold me to account for it. If it's not there in the first place, and it's for us to lobby government also about the right, fairer funding for Hillingdon's residents to get their social care.
So in terms of the robustness point that Councillor Puncher makes about them coming up to budget setting pretty soon, in terms of us seeing this, I think in the past what we've definitely not seen is the calculations behind that, and I think this time round we'll definitely want to see some of that, because in order to give us confidence that we're actually dealing with numbers that are realistic, I mean, prediction is impossible, but we want to be assured that the process is robust to predict. So seeing that would I think, I was going to say super useful, is a must this time. Matt, do you want to come in on that point?
Thank you, Chair. I've worked in several organisations where budgets haven't been delivered. There's a number of lessons that you learn as you look at those. We've introduced a formal process, so the only way that a change can get into the budget setting process is if someone completes a simple 2-page form. So we have evidence that someone has said, yes, I am proposing that. That form includes the dependencies on delivery, it includes the timelines, it includes the risks, it includes the impact on stakeholders, has a separate sheet for all the workings, so no one can say afterwards, I don't know where that number came from, the person's left, we've got no idea. The formal process will split within the budget schedules you'll see, not just, oh, it's growth or it's a saving, it splits into category of savings, so, or growth. So is it the demand element of it? We want to see the model that backs up the demand. Is it due to inflation or price? Why do we think that one service has got a higher than average level of inflation? Show the evidence for it. It includes an element if the budget in the current year is wrong, a rebasing, so we can see that's just getting to the proper starting position. We've held challenge sessions where we've gone through some of the larger key data variables. The adult social care is one, the parking is another, homelessness is another. 3 examples where the demand modelling is such that we've gone into detail on that. We've reflected on current year variances and said if the service is having a variance in year, either as a saving or growth spending pressure, is that reflected and will that continue next year? Because we don't want to miss pressures in year that will come back and bite us if we don't reflect the need for those. We do have a proposal form for all changes. You will be seeing more in the run-up to the consultation budget due to be released towards the end of December, and then of course we go to full council and cabinet in February for council tax setting, but the consultation budget will be out before the end of the year.
And so you'll come to us in June, basically. January, sorry, June is is realistic. So you'll come to us in January, where actually what you've talked about, which seems very interesting, you'll talk again to us through it, but with the numbers, so we can test that sort of process.
Yep, we'll do it as a team because it's Sandra's budget. I'm here to help.
Of course, yeah, as a team. Yeah. Team. Okay, one more question and I'll move on to others.
Sandra, I just think that actually I'm really glad to see all the stuff in AI, but my point was that actually we're piloting it and it's coming into fruition now to month 6 of the budget, whereas it was put in as a savings right at the beginning of the budget. So I think that you will have more of a chance of that savings coming into the next year potentially, or actually aligning that to what's going to happen next year. In terms of the modelling going forward, and I'm really glad to hear about all of these things, I would really like to see those workings out in the budget setting. Just like actually you've talked us through some of this stuff, but I just felt that I wanted to see more narrative around the budget reporting so that I could actually understand what some of these figures are, because I'm not in your workspace. I don't kind of know the day-to-days of everything that goes on. We're just looking at a report and I'm looking at figures, and then all of a sudden I go ping like this. Whereas actually you've got a lot of detail that you could already tell us. That would be helpful.
So can I make a suggestion? Well, obviously the first one is that we've already discussed. When we come to this on the 20th of January, not June, we will be diving more into this stuff against the real numbers and the real prediction. But I think what Councillor Punja is asking for really is actually some quite detailed discussions through the document. So maybe as a committee we need a training session to, and then obviously stuff we want to bring in the public, we can bring in the public. But because we did have there was an overall training session for us about scrutiny of budgets, which was very useful, but it was very high level. But actually, maybe looking at these numbers now, maybe as a committee we need a training session on these numbers. So, when we have this time here, we can unpick them. So, I think that's something we'd like to set up. I think, yeah. Okay, great. So, Councillor Smallwood, and then.
Thank you, Chen. And Matt, I think your analogy about the 98% was really good. If only Hillingdon was getting its fairer funding, I think that would be 99%, and that's almost there. And I don't think many people like being the 1%. So
And maybe, whilst I'm not a member of this committee, that might be something for you to have as an agenda item, and maybe get the Cabinet member to help Sandra in the, I'm sure she is, because she's very diligent in the lobbying for that money, and something that we as the political wing of the council could help support, because I think that's incredibly important. I don't know whether that's something, just a recommendation, Chair. I just wanted to understand, and without mentioning the case, Sandra was very helpful to me with a particular case for a resident who is very dear to my heart, in dealing with where common sense needed to outstrip numbers for what was a relatively small amount of money. I just wanted to understand what stringent processes were in place when making funding decisions on individual cases, on projects, etc., but also where, if it doesn't quite meet the number, the person's needs allow for that number to move, and what processes there are in place, which we'll never see in the level of detail because it would start to bring people's personal information into the public domain. How does that work? Because I think this is a particular portfolio, along with maybe children, families and education, which you don't see in corporate services and resident services, where I'm privileged to be the chairman. There is some really human cases here where you need to really... Common sense just sometimes needs to prevail, and I just wanted to understand what stringent processes were in place to protect the numbers and to keep the budgets in order, which should always happen regardless of where the budget is, but where is the sort of flexibility and the sensible common sense approach? Thank you, Chair.
So, thank you. You're quite right. We're dealing with people, not widgets, not grass cutting or something similar. So we have to consider, and that is all embedded and built into the Care Act. So everything that we do for residents is around eligibility, and people are eligible or not for services. So they're assessed under the Care Act, and we determine the value of what we should be providing for them in something called a resource allocation system, the RAS. So within our system, it says this is the needs that person has. This is how much roughly it should cost to provide those services, and these are the types of services that somebody needs, i.e., as an example, they need some home care, they need to be seen 3 times a day for about half an hour a day, half an hour a visit, 7 days a week. They need some daytime activity and maybe a visit to a club. That goes off in our system and it's reviewed. It goes off to be sourced through our brokerage service, who look at what the cost of that will actually be against what the resource allocation is, because the two things don't necessarily marry up, as I think you found out recently. So the price of one care provider can be very different, which is why we try to work with set number of providers so that we can control cost and quality, and often we also have people want to choose who their provider is going to be and where that's going to be. So we set some parameters around what a reasonable cost is within the resource allocation, and then that comes to a panel for quality and cost purposes. Now, the Care Act is very clear that you can't make a decision based on cost, and you absolutely can't, because we have to meet the need. So I can't provide a service to somebody just because it's the cheapest. I have to provide something that meets the individual needs of those residents and how that is best met. So that's the priority always, but obviously I have to consider best value. So we do our very best to negotiate with our providers. We form really good provider relationships, and we ensure that in the event that we have a case where somebody probably needs to stay where they are or continue with what they're getting, despite the fact that it's slightly different to what we would expect it to be, if that meets the individual's needs, then that's how that package of care will be delivered. So in an ideal world, you would be within that resource allocation. That isn't always the case, but you will have winners and losers in terms of price in that. That's how processes are kind of considered and how needs are met. But it's driven by the Care Act.
Can I just place on record that my experience of this, where the odd case falls into that complicated grey area, I received an excellent service from Sandra and her team. I won't go into the details, but it was probably the most important case I've dealt with, and the one that I still think about most days in the 3.5 years I've been a councillor, and Hillingdon does have that in place. It can't do it for everybody, and this isn't, you can't, as Sandra said, you can't do this every single time, but when the hour of need was needed, the service actually stepped up and wasn't just rigid and saw people as people and not numbers as numbers. So just to place my thanks to the team on that.
Thank you, that's very good feedback to hear, and actually sort of thankfully the CQC report sort of does say that, so it's, you know, that is acknowledged, so, but it's great to hear that your personal experience is very positive. Councillor Bassett.
Thank you for that report. It's very comprehensive, lots of data, very dense. Still on the theme of fairer funding, looking at the appendix document which refers to deprivation and says that Hillingdon was ranked 90 out of 153 of the councils, and therefore not as deprived, but we have got several wards in Uxbridge and South Ruislip and Hayes and Harlington which are actually quite deprived, looking at the data that we received from the council and the shading on the map. And then also the paragraph where you say that Hillingdon spent £1,084.43 per older adult, and it was less than the spend in England, minus 7.1%, and then there's another stat which says minus 20%. So how does one get fairer funding? Who do you lobby? Who's in charge of that?
So the allocation per resident is kind of the overarching need for us to have a good recognition of who needs to receive that funding. So that's kind of, if I park that to one side for a minute in terms of how much we're spending per resident, the value that it is costing for us to provide services is good value. So we're negotiating well with providers, we're ensuring that needs are met within the available resources that we have. So that's kind of the one point. In terms of the indices of deprivation, we have some extremely deprived areas of our borough, and that has actually, the deprivation has increased most recently in the most recent published data. So at level 2, which is almost the highest levels of deprivation in some of the areas in the south and in Uxbridge. So those are the areas we need to focus our work on in terms of social care, in terms of public health, and ensuring that we're making a change in how we're supporting those individuals with the resources that are available to us. I think what the report is pointing out is that what we do with our money is positive, it's good, we're getting best value out of it. What I'm saying in terms of fairer funding across adult social care as a whole, I'm sure every DAS in the country will be saying the same thing, is that actually adult social care needs to be further funded to ensure that we can make differences to people's lives, people can be more independent, they can make better choices about the care that they're receiving, and that we're not having the level of pressure in adult social care budgets that we're seeing across all of the departments across London, quite effectively.
Thank you. The government needs to give more money to everyone to do this. Well, that's my comment anyway. Councillor Martin.
Thank you. Over the years, probably decades, there's been it was cheaper to outsource to third-party suppliers from a local authority, and we saw that in many corporate businesses where I work as well. I wonder now, with the increased cost for various reasons for third-party suppliers of social care, whether it's now beneficial or cheaper to bring some of these services back in-house as a local authority, because surely the saving that was created initially is that gap's kind of squeezed, isn't it, and may now be in a deficit. I don't know if there's any value to coming back in-house.
So I've been here long enough to see it do all of those things. It's a full circle, and we are absolutely reviewing how it's managing the stability of the market at the moment, which is a very commercial market, but the cost of living crisis has really impacted on care providers. One of the things that we have to keep very close in thought is around the fact that there are some employment and legislation changes coming next year, and we need to make sure that that doesn't impact on costs of us delivering some of those services ourselves. But as it stands at the moment, it's a more cost-effective model that we can offer care of good cost, good quality to local people in our own trading company. So yes, at the moment it is looking like it's going full circle. In 2000 we outsourced all of our older people's care to other contracted providers, and we're now bringing it back again. So it was a much more cost-effective model at that point in time. So it's changed.
Great. Martin, go for it.
One additional observation. If you look in Appendix 2, the graphs, and these are just some of the graphs that we've got, and they're looking at the movement between the end of the 22-23 financial year and the forecast for this financial year. You'll see that one of the positive stories is that the volume of home care has come down as the volume of direct payments has gone up, and that the price for home care is pretty stable. And that's because the way that home care is procured by the council the council has much more influence on what happens in that market. By contrast, if you look at the graphs on nursing care and on supported living, those sectors of the market at the moment are much more provider-led. And the work that's being done to increase internal nursing capacity, even with the changes that are coming in next year, it potentially gives the council more influence on the market. You don't have to do it all yourself, but if you have sufficient capacity, you're in a better negotiating position with independent private sector providers.
Thank you, that's very useful context. Okay, I'm going to bring this item to a close now, so thank you very much for coming to talk to us. Obviously, when we meet again in January, we're going to be discussing this a lot more as we move into budget setting. So feel free to leave if you wish, because we've only got a couple more items to go through on our agenda item. So I move to the Cabinet Forward Plan. Is there any comments on that, or are we happy to move on to the next item? We're happy to move on to the next item, that's fantastic. Okay, and the work programme. So Nikki pointed out, almost by serendipity, we're actually going to have the CAMS update in January. It says February here, but it's going to be January anyway. So we'll be able to dive deeper into the point that Councillor Smallwood raised. Good forward thinking from there. So which is really useful to get back into that. So that's really useful. Obviously, at that meeting as well, it's going to be about the budget setting and getting into all of that, and we're hoping that the Cabinet member will be able to come along as well, because obviously it's important for her to be here, as well as Sandra and Matt and Martin, to talk about that. I did wonder, and Nikki, something maybe for you to take away and think about, we have the HHCP place-based service delivery down for January as well. It already feels like a really busy meeting with the CAMS update and the budget stuff. I wonder if that could be moved to February. That makes sense, doesn't it? Yep, Councillor Puncher.
Could we, with the CAMS update, because we made some very kind of stringent or strong recommendations, and it would be really good to kind of evaluate against those recommendations, please.
Chair, as part of the attendance, I have asked Vanessa to provide us with an update on the implementation of recommendations from the review that was undertaken by the committee, and also requested that the newly appointed Children and Young People's Champion be invited to attend. So that's been spoken about previously.
Would you be able to circulate those recommendations to us, because there's some people are new here, so that we've just got them as a benchmark against us? Yep.
The whole report even as well. That's just useful. Yeah, good stuff. Excellent. So are we all happy with the work programme now? Yeah, good stuff. Okay, well I'm going to call an end to the meeting. So thank you everybody.